Hi, my name is Joseph Abraham. I am a PGY2 internal medicine at Unity Health, Searcy, Arkansas. Today I like to present a very interesting case under name SCAD. Keep it in mind and do not rush. SCAD stands for Spontaneous Coronary Artery Dissection. So our patient is 67-year-old Caucasian lady who presented to the ED with chest pain and shortness of breath for 12-hour duration. She described it as sharp stabbing and she graded it as 9 out of 10 in intensity and does not radiate anywhere. Her initial EKG shows very minimal and subtle ST elevation in the inferior leads, which by that time was not qualifying for the diagnosis of any ST elevation myocardial infarction. Thus, her initial troponins were negative. So they started her on just medical therapy and she reported that the symptoms improved. What happened the next morning, she got another episode of minimal chest pain plus elevated troponins. The troponins were 8.16 by that time, but her EKG was normal again. He was taken to the cath lab for further investigation, and what happened, we found pulpit lesion in the LCX and first obtuse marginal artery. But due to her risk factor of hormonal replacement therapy, the operator decided to stop the procedure at this point and stop hormonal therapy, start the patient on dual antiplatelet therapy, and revisit the lesion in 2 weeks. During these 2 weeks, the patient reported a couple of episodes of chest pain, but not as severe as the initial one. When she came back after the 2 weeks, the lesion was less than the previous one. So the operator decided to go ahead and wire the lesion and put a stent in it. And the final results, as you see in the slide, it was ME3 flow was achieved. The moral of this case, a couple of points. First, our patient has no known conventional modifiable cardiovascular risk factors, like she didn't have hypertension, diabetes, dyslipidemia, or smoking. Her only risk factor was age, sex, and prolonged use of oral hormonal replacement therapy. She started using hormonal therapy since 2017. So she'd been using this for almost 4 years. And there are multiple reported cases about spontaneous coronary artery dissection after prolonged use of hormonal replacement therapy, not only the oral one, but even the topical usage of the hormonal replacement therapy. So, number one, this is a message for the emergency doctor and the internal medicine doctor. If you have a female on hormonal replacement therapy for quite a long time and she complaining of chest pain but no other risk factor, she should be further investigated. The right investigations for spontaneous coronary artery dissection is coronary angiogram, but the gold standard is to do the orbital coherence tomography or CT angiography. This is the gold standard investigation for spontaneous coronary artery dissection. I hope this case can raise the awareness about these rare findings and can help the emergency doctor and the internal medicine doctors save more lives with focusing on this rare presentation of acute coronary syndrome in females on hormonal replacement therapy for a long time. Thank you.